It strikes me as I hear all of you speak, and certainly with your personal experiences, that this really is going to require some really different thinking. This is sort of the Uber economy in healthcare. How are, and I have a number of doctors in my family, and I know oftentimes they're like, well, we have to decide. Sort of doctors knows best. And this is turning this on its head a little bit, where we're going to use our knowledge and understanding, but also the technology, which is probably more precise in many cases. So what kind of resistance, if any, are you? I think you've highlighted a lot of resistance, so that's very helpful. But what kind of resistance are you seeing, if any, hopefully not much, to this kind of thing, and what can we do to assuage that resistance that the medical field might have? Mr. Reed.
Yeah, I think one of the things we have to consider, it's very easy for us in the technology industry to say, oh, the doctor is wrong, and be disruptive and welcome disruption in their lives. But what I found is that physicians are as frustrated by the regulatory requirements and the barriers and the questions about reimbursement as anyone. The AMA had a recent study that showed a 30% decrease in efficiency due to the way that the failure of EHRs to be interoperable had created, and frankly, bad user interface design. So I think we have two real problems that we're facing with physicians. One, physicians are uncertain about how to accept that data and the accuracy of the data that they might accept. And then two, what are the liability that extends to them if they accept that data and they don't act on it? And then the overarching question is, if they take the time to review the data and engage with the patient in that way, how does that figure into their reimbursement? So I know that this committee's jurisdiction touches on those on edges, but we are all frustrated with the physicians, but I think I would speak for my meetings with the AMA and others in saying that they're frustrated right along with us.
What I work on, retinoblastoma, it's highly specialized. So pediatricians, ophthalmologists, they actually know, peer-reviewed studies have shown that mom, then grandma, then dad are statistically the first people to catch the symptoms of retinoblastoma. And the primary test that the pediatrician uses, shining a light into the eye, this is called the red reflex test, it's notoriously ineffective and everybody knows it. So the doctors that we're working with, I mean, they love it. I haven't encountered any resistance from the practicing pediatric or ophthalmology or oncology community.
That's great news.
So type 1 diabetes, I think, is a great example of this. It's one of the only diseases where you are literally prescribed a deadly hormone, right? If you take too much of it, it will kill you. There's a shortage of endocrinologists in this country. Most endos see their type 1 patients 4 times a year for maybe 15 or 20 minutes. The other 361 days a year, the patient is on their own. So most endos love engaged patients. Patients who engage with their data and understand what a fine line it is to deliver good insulin doses do better.
And in terms of the data sharing too, when we're talking, as mentioned earlier this morning when we were talking about, cancer patients wanting to share data and get to share that, I guess maybe we need to have some legal changes, some liability changes. But do you think that in that area, as we share the data, you're going to see like, well, this. So this is the the person who's done the best with type 1 diabetes, not doing any damage, have done these things. So as you're tracking through, you sort of have a goalpost of all these thousands before you that you can stay in the zone to get, the A level of performance from something like this.
By and large, in the world of type 1 diabetes, there is not resistance to sharing data. People understand that by sharing their data, they're doing better for the community. And when there's a large pool of data, it means that not only doctors can see how patients are achieving effective therapy, but you can even start imagining effective ways of computing insulin doses. When my daughter walks into California Pizza Kitchen and orders the 5-cheese margarita pizza, she should be able to look on her phone and see how did other 16-year-old girls who ordered that same pizza dose for this effectively. and help to come up with a better insulin dose that way. So by liberating the data, we allow for more engaged patients and much more effective therapy.
And I have to imagine as a parent, that gives you a lot more peace of mind, too.
That's right.
Yeah. Right.
One interesting thing we found is that actually patients want to control their own health data. So when we collect tracking data about their pill taking or the number of seizures, they actually don't want that to go directly to their doctor. They want to receive it and then show it to their doctor potentially, and they're quite willing to come in for appointments and have their device optimized. But that's an interesting feature, but it's one that we use also. So we want to optimize our graphing and show relationships between missed pills and seizures. We have a participant like me graph so they can see how other people with the same condition, same age are doing. But that was an interesting finding, yeah.
Great. So bringing it back to, kind of doctors using apps, we actually make apps for doctors, right? So we've encountered lots of resistance. The first is, as Mr. Lipinski pointed out, there's 100,000 apps, right? So you're really going to ask a doctor to use 100,000? No way, right? And so basically, when we talk to doctors, we have our own app, but they're like, put it in the EMR. And really kind of, if you think about the EMR as the Salesforce sort of model where you basically stick a whole bunch of apps and the doctors don't even know they're separate apps. It's just a widget within the app, right? And so you have one for blastoma, you have one for all these different things, right? So that's kind of, I think, where the future is going.
So we really need to make that just available directly for the patients and not having any blocking things, because the doctors can't possibly know all the things.
Or right, make it easier. So HHS is just putting this interoperability thing, freeing the data to allow doctors to be able to say, look, in my EMR, I can control it how I want to control it with whatever apps that I want, right? So that's exciting. And then when you think about, again, this workflow problem, so again, if you were trying to diagnose or trying to use any of these things, you're saying I have to do a new thing, right? As a doctor, I used to do this, and now I have to do something else, right? And so that's one of the biggest things that we've faced is how do we reduce workflow for physicians, right? And so that's.
Right. Yeah. Thank you very much, and I'm over my time, but I really appreciate it. Oh, I'm so sorry.
If I could borrow some time from Mr. Lipinski really quickly. I think it's interesting that Dr. Shaw, Mr. Look, and Dr. Krauss all talked about access to data. But one of the problems that we do see is that much of the guidance around remote patient access to data on HIPAA predates the iPhone. Yeah. Now they've done some new stuff, but 2006 for the guidance, iPhone came out in 2007. So as you're considering the places where there's movement, there is room there.
Thank you very much.